We always talk about provider well-being, physician well-being. What can we do to help with burnout? And I think the answers are really simple. It's not have the doc go and present on a case. Yeah, that can help with education. Let's just make their lives easier.
Welcome to Revenue Cycle Above the Bottom Line, the podcast where we dive deep into the world of revenue cycle management. I'm your host, Tim Reiner, and in each episode, we sit down with industry leaders, innovators, and experts to explore challenges and strategies shaping the future of healthcare revenue cycle. Whether you're a seasoned professional or just starting out in the field, this podcast is your space for thought-provoking conversations, actionable career learnings, and discussions about the latest trends you need to know about. Thanks for tuning in, and let's get started. Today, I'm joined by Dr. Chris Riccard, Vice President of Hospital Medicine and Clinical Documentation Integrity at AdventHealth. Chris is responsible for strategic and operational initiatives for over 1,000 hospitalists and more than 300 clinical documentation specialists across 50 hospitals. Chris, thanks so much for being with us today. Tell me a little bit more about your role and the areas you have primary responsibility for.
Thanks, Tim. My role, I'm the VP of Hospital Medicine and CDI, and more recently I've taken on our credentialing process.
Oh, okay.
So as we think about those three areas, specifically hospital medicine, we have about 1,100 hospitalists now throughout 50 plus hospital medicine programs or groups at each hospital. And I get to work with all of those physicians. It's quite fun. I also get to work with our CDI teams across each of the campuses, and now about 300 different med staff team members as well.
And for the kind of layman, a hospitalist is the attending physician that takes care of inpatients, essentially. What more would you add to that definition?
Absolutely. So think of a hospitalist as the primary caregiver in the hospital setting. So years ago, your old family practice or internal medicine models, those providers would come into the hospital, take care of the patient, go home back to their office. Now we have providers who are dedicated to doing that work in the hospital day in and day out.
And then handing it back off to
Yes.
the primary care. Yeah. So as a physician, can you give me a little bit of history about how you ended up in healthcare? You mentioned earlier you weren't really from a healthcare family. So how did that passion for healthcare begin?
Yeah, so that's interesting. As I look back to my childhood, at one point I think I wanted to be an astronaut.
Mm-hmm.
And I realized that sitting on a lot of gas that shoots you up into space is a bit risky.
Yes.
And would probably not be the future for me. At the same time, I had an uncle who had an unfortunate outcome following hospitalization.
Mm-hmm.
He had a cabbage and 6 days later died, I think, for medication noncompliance.
Mm-hmm.
Unfortunate story. You don't take the anticoagulant you need, you're at risk for developing a clot, and that's what happened. I then subsequently attended a health magnet program in high school, and that really sealed the deal for me. I'd always been attracted to the sciences, the medical terms, the diseases, and in high school, being part of a health magnet program really put me in that setting. I got to experience it and learn that, and coming out of high school, I immediately knew I would enter healthcare.
And then you must have had some influence on your sister who later became a nurse as well. Is that right?
So she also attended that same health magnet program, and it really was a great foundation for learning the basics of what does healthcare look like today in the United States.
Well, that's a great service. I'm sure there was many others in this community that were impacted. So was there a particular lesson or mentor that you can remember that was influential to your professional development?
Yeah, I've been blessed to have mentors really throughout every stage of my career. When I think back to even early college, I had a professor in the health sciences department who partnered very closely with me. She's responsible for, I attribute where I'm at today back to her.
Yeah.
Partnered with me, helped me through the medical school application process, was really not just a friend, but someone who provided guidance when I needed it.
Yeah.
That same mentorship carried forward into residency, similar relationship. In residency, it's a tight-knit group where you're learning medicine in a high-stress environment. Yeah, some of that at times, but it's great to have faculty that you can lean on when you really need assistance and feedback. Where am I going? And teaching behaviors, not just medicine. And then even my early career as a hospitalist. I'm a hospitalist by background. When I was fresh out of residency working as a nocturnist, I still remember our CMO, who I have a great relationship with today, no longer is working. He's retired. I still go to lunch with him. He would partner with me, because I was also a new leader at the time, and help walk me through hospital initiatives and quality opportunities. And so I actually still connect with him for feedback and to keep in touch with one another. So you mentioned mentorship, and I cannot stress the importance of not just having a mentor, but mentoring others as well.
Yeah. And so was that same physician, CMO, was that who got you interested in CDI?
Yeah. So when I think back to my early days in CDI specifically, yes, that physician leader, I was a new medical director, and on the team I was on about 10 years ago, length of stay wasn't really widely discussed with the physicians.
Yeah.
And so we had to start those conversations, and we partnered together to do that. At the same time, CDI in that market I was working fell under care management. And so we had a care management leader who was a great partner in really mentoring me on the day-to-day ins and outs of CDI and why it mattered for a physician.
Yeah.
How can partnering with CDI help me be a better clinician and help my patient outcomes?
Yeah. So let's pull the string on that a little bit. So explain what CDI is. Clinical documentation, is really important, but like what is it, and unpack that a little bit.
Yeah, so CDI, clinical documentation integrity, if you think about the basics of it, it's what we document in the chart so that our coders and our end users can reference the information to report to public entities for billing and CMS, or our other clinicians can review a record and pick up where a clinician left off. So at the heart of clinical practice, clinical documentation is what ties all of it together. It's the, you've heard the saying, if it's not documented, it didn't happen. Well, the reality is it did happen, we just don't know it all of the time. And so we need everything that happened in the record so that anybody who wants to review that case, whether the patient's still in the hospital or after the fact, has the information at hand just to do that.
I think it's important, has been elevated recently just because the coding and documentation is so influential to the reimbursement. And so it's the lifeblood of kind of the financial aspects of healthcare. So why did folks care about length of stay back in those days when you began learning a bit more about the financial aspects of inpatient care?
Yeah, so length of stay it's always been a key measure hospitals have focused on. When I think about hospitals and resources, there's no greater resource than the bed the patient's in. And when length of stay is not appropriately managed, that bed resource becomes limited, and you can have patients waiting in the ED, patients not able to get timely care. And so really, to be an efficient and effective healthcare system, you have to manage your length of stay, which means managing throughput and those resources. Otherwise, everything backs up downstream. Length of stay has always been talked about. I think as we've come out of COVID, given the financial pressures and really just the disruption that occurred in healthcare through the pandemic, managing length of stay is now a top priority, where I think it's always been discussed, but may not have always been the focus area.
Yeah. I think it's, in my mind, it's important now because we're in a time of scarcity. Like there's not enough inpatient beds in some markets, and we are in Florida and fortunate to, I guess, be in that busy part. And so we have to have that throughput. And then, financially, if you're keeping people longer than is necessary, it's not a good thing financially. So I think that kind of underscores the priority. Tell me a little bit about the connection between quality and sort of CDI and why that's so important.
Yeah, so from a finance standpoint, what we document absolutely will drive coding and how we're reimbursed. I think what often goes missed from CDI is how CDI and what we document impacts all of the other initiatives and data elements we report to external entities. For example,
So we're talking about like Leapfrog and like star
CMS
ratings.
star rating, Premier, Vizient, anybody that payers that may be looking to partner with AdventHealth, they want to know that we're going to deliver the best care for their patient population at a reasonable cost. And quality is what will determine that for them. So if you think about it, you may have a patient that was admitted and didn't have a great outcome. Depending on how that's documented, it may look like that outcome is a result of their hospitalization, when in all reality, the patient may have arrived to the hospital with that already ongoing.
Like your family situation is an example,
absolutely.
Right? So,
and so CDI helps capture the reality. What's happening with the patient? Was that a condition that was present before they even got here, or was that really a hospital-acquired condition?
Right.
Quality is key to a high-performing CDI program, and more we're finding areas where CDI can really help drive quality measures.
Just better documentation is going to bolster that quality story as well as the financial story that
Absolutely.
goes into it.
And when I think about the quality aspects, CDI can directly impact mortality, length of stay. Length of stay is a finance measure, but if you've ever had a relative in the hospital, know they're ready to get out of there most of the time. And if you've been the family member of that relative, you're ready to get out of there. And so being in the hospital is not always the best place for well-being for a patient. Then you look at PSIs and HACs, which are different quality measures entities look at to determine safety of care in the hospital system. CDI directly ties to every one of those and can impact how we do on them.
This is a two-part question. The first part is sort of in an era of electronic medical records and ambient speech becoming sort of more and more utilized, what are some best practices for physician documentation? It used to be in the old days, there was like dictaphones or phones that you would dictate into, right? And so we've come a long ways to speech recognition and ambient speech. And so kind of how do you see that changing? And you probably trained in a time where that transition was happening, right?
Yes. Yeah, so that's interesting. I remember my first year of residency, we were in the middle of converting from paper charts to the EMR.
There you
go. So I think I handled that easier because I wasn't brought up in that paper system. And I was able to train in the new system and adapt quite quickly. So you mentioned DAC, or ambient, or DAX is another name for a product for us. When we think about those tools are going to be game-changing and truly revolutionary for the future of healthcare. I think of my converting from paper to electronic and how that may have been easier for me and more difficult for some. Those who come into healthcare now and have ambient technology available to them are going to practice in ways so different than I ever practiced, and we still practice today. So imagine your patient. I'm coming in to talk to you, and actually, just like we're having this conversation,
the microphone's on.
I'm not having to look at a computer. I'm not having to take notes because everything we talk about is being captured. And then when the visit's over, because I've been able to focus on you and the whole you and not have to keep looking away and distracting myself or placing orders, after our time together, which is longer because I'm now more efficient, I then go to a computer. My note is there for me. Maybe even some of the orders we talked about for you. And I just simply have to review it, edit it a bit, sign off on those orders, and move on. It is going to be game-changing for the future of healthcare, not just for our providers and their well-being, but for the patients, because now you're going to feel you've had more time with me. And then when we think through quality, imagine how much more I'm able to learn about you because I have extra minutes to just connect with you and talk to you about what's going on.
Yeah, it's going to increase the, I think, perception of like the experience for the patient. So, so ambient speech is huge. Are there some other technologies that you think are coming or in the works that will also change the game?
Yeah, there's multiple technologies out right now. We're in the process of, we've signed an agreement. We will be partnering with another entity to really help our providers with the second half of the documentation. So for those who may not be as familiar, most providers document in a way where the first half of their note is much of the conversation. It's what Tim just told me.
The history
it's
of
your
what
history, yeah, and what you perceive is going on. So you tell me you have belly pain.
Yeah.
The second half of most of our notes tend to be what I think. It's the assessment. It's the plan of care. The ambient technology is going to do a really strong job in capturing that first half.
Yeah.
The other technology we're exploring is going to use AI, true AI, not rules-based technology, to review the entire medical record. 10 years, for example. If you've been coming to me for 10 years, it can look at your inpatient, your outpatient records, and then recommend to me the things I might need to document in your assessment and plan based on all of the findings in the chart. Imagine those two tools partnered together.
Yeah.
So we have the conversation, it's documented now. I go to a computer, AI has helped draft the assessment and plan. AI is able to read far more than, I would never be able to read 10 years of records across healthcare settings, where AI can do that in seconds and summarize that. I think future state is going to be a partnership of those kinds of technologies that make me more efficient while helping me capture things that may have otherwise been missed because I didn't look 10 years back at an outpatient result.
I imagine that's better for the clinician, but if I'm thinking about the patient, it's got to make it safer for the patient too, right? Because there's something that you might have missed in reviewing those 10 years of records that, the system's not going to, our algorithm is not going to miss that condition. So what challenges do you see that are like most frequent around like documenting medical necessity and CDI type elements? Like what are the key areas that are barriers?
It's documenting it.
Yeah.
So thinking through medical necessity, our teams that are reviewing patients as they're coming in our doors day in and day out, I consistently hear the greatest opportunity is having the medical necessity highlighted in that first note. And I've had numerous conversations with hospitalists who tend to admit 80% of our patients here at AdventHealth about the importance of a thorough and accurate H&P, history and physical, when a patient's first admitted to the hospital. I'm also a strong believer in the H&P. That really sets the plan of care for the patient. It's the first note. It's going to tell the story to everyone who comes after that admitting provider. It's going to start the train in motion. And so we need it to be as thorough as possible. And that's where tools like ambient and these AI documentation tools may be able to help those providers, especially on admission.
So like I'm sure a lot of our admissions come through the emergency room. Are we starting to use the ambient in the emergency room setting, or is that a little ways out?
Forthcoming.
Okay.
So we've initially rolled ambient out in the outpatient setting, and it was about 3 weeks ago, met with some of our providers in the outpatient setting for direct feedback. That mentor, that former CMO, is one of those outpatient providers who's retiring, and he was explaining to me that now in a 30-minute or 45-minute visit, whereas historically you'd have about maybe 15 of that in FaceTime with the patient, because then you got to take the other 15 minutes of the visit. You got to go do all the busy work. Yeah, place the orders, do the note. He's spending that full 30 minutes in face-to-face conversation with the patient. He no longer has to go home and finish his notes. Everything is done. It's efficient. And so it has been an incredible success in our outpatient setting, and I do anticipate having it available in the inpatient setting here in the near future.
So reducing that pajama time you
Absolutely.
hear about and read about. Yes.
We always talk about provider well-being, physician well-being. What can we do to help with burnout? And I think the answers are really simple. It's not have the doc go and present on a case. Yeah, that can help with education. Let's just make their lives easier. Make it so that when they go home, if they want to have dinner with their family, they can. They don't have to worry about getting in the chart and writing something down because they may have forgotten to do earlier.
Before we continue, we wanted to thank you for tuning in. If you have questions or thoughts or just want to say hi, we'd love to hear from you. Send us an email at revcyclepodcast@adventhealth.com. That is REVCYCLE podcast@adventhealth.com. If you enjoyed this episode so far, be sure to like, subscribe, or follow so you never miss a new episode release. Now, let's get back to the rest of the episode. I want to know, like, what are some of the best practices of a mature CDI program?
As I think about CDI and maturity, I really do believe it's being able to move past the financial side of CDI and getting into that quality space. I go to all of these conferences and meetings where everyone's focused on CC capture, MCC capture, DRG optimization, and absolutely at the heart of it, yeah, we should be there. And so those are absolutely important measures. We do impact finance for a health system. Nationally, it's important. But being able to transition from that and add quality is key. And so I would suggest a mature CDI program is not just delivering on those finance measures, which are absolutely important. Also, it's delivering on those quality measures. So again, what is the impact on your readmission rate? Could we do something differently to more accurately reflect how sick that patient was, which is why they readmitted? If a patient has a bleed, a post-op bleed, are there criteria that the patient actually met that could exclude them from us listing them as a post-op complication? So CDI's future is really more than just revenue. It's helping truly, it drives how external entities look at the healthcare system, and it's those quality measures.
So basically, like, just to distill it down, it's going further than just like I'm going to capture the complications and the major complications and comorbidities, and I'm going to actually tailor some interventions, you know, right? So it's moving past just like pure like capture of documentation, but then like kind of fashioning some interventions that improve the quality.
We have the best of the best nurses reviewing these cases, ICU trained, ED trained, OR trained, and they're able to pick up on opportunities and diagnoses and patterns that can sometimes go missed. And so I think it's a great example of the entire clinical team coming together, partnering together to try to improve patient care.
So CDI and coding collaboration, you know, play an important role in the success of middle revenue cycle. How can these teams work kind of closely together? And in your experience, like, how have you seen that, you know, partnership be important to healthcare organizations?
They have to work closely together. I've found that our markets, both inside and externally from AdventHealth, talking with peers, those who succeed in this space have a tight partnership. And I don't think that partnership has to simply just be, well, the CDI team and the coding team have the same leader, so they have to align. Here at AdventHealth, coding reports up through you, CDI reports up through clinical, but our teams have incredibly tight partnerships. I'll brag on our corporate teams here a bit. Our corporate CDI director and our corporate coding director, there's not a week that goes by where they're not talking through initiatives with one another. If we're rolling out something from a CDI standpoint, how does that impact coding, and vice versa? Because I think to drive success in this space, both for coding and CDI, there has to be a partnership, and we have to have alignment, and we need one to help the other succeed. So success requires we both do well. And I've seen this with our markets where our CDI teams and our coding teams are well aligned, they're partnered together, same success follows.
I think that is so important, like that you mentioned earlier, that kind of triad of physician, professional coder, and like CDI nurse. You know, I think that's a part of the recipe that the collaboration sort of has to consist of. Interesting. So what other strategies have you sort of seen as effective in engaging physicians to get kind of buy-in to document more? I imagine like there's a lot else that physicians are trying to accomplish other than, you know, touch up the documentation. So, you know, how have you seen them best engaged in that effort besides the mobile example?
It really involves efforts that make it easy. Make it easy is one of our service standards. And if we can't make it easy and include it in their workflow, it doesn't matter whether we're inpatient, outpatient, across the spectrum of healthcare, even for our nursing teams, we're unlikely to see success. And so we have to find ways to engage our clinicians as we're doing this work to get their feedback on will this work, and integrate whatever solutions we roll out in their workflow. One of the tools we're exploring right now, thinking about the future, is a way to automate, similar to what that other tool I mentioned that assists with the assessment and plan will do, a way to automate diagnosis capture within their note. So make it easy.
Yeah.
Every provider's writing a note on every patient every day. That's their workflow. So rather than have them go to another part of the EMR to document something so we can capture it for coding, let's have our EMR automatically put it in their note, make it easy for them.
Yeah.
They then review it, it's there, they say, yes, I agree, and they move on.
Yeah.
So we've put a solution, we've embedded a solution in their workflow that requires minimal change on their part that will help document conditions, our coding team capture them, and potentially pick up on things that may have otherwise been missed by our clinicians.
And at the end of the day, it just supports that complete record, right? So for our department, we've been on kind of an aspiration to be a world-class revenue cycle. And then moving in the future, as we look towards our 2030 vision, to being preeminent. What does that mean from your perspective? And is it too audacious of a goal to have CDI, reach preeminence?
That's an interesting concept. In an ideal world, from a clinical documentation standpoint, and none of my CDSs, if you're watching this, get anxious. You will always have jobs. But preeminence in the documentation world is ideal state. You don't need a CDI department. We're not needing to send queries. We're not needing to review records. Now, the realistic side of me tells me we're a long ways from there because we don't have the right tools, processes in place to even be able to deliver on not having to send queries. But preeminence in the near future for CDI, I would suggest, is rolling out those tools that make it more efficient for our docs to document up front. And I would expect once those tools are rolled out, we do see a decrease in the need to send a query. So the near-term preeminence for CDI is decreasing the need to send a CDI query.
Yeah, because you've already captured.
We've got it there from the very beginning using all of these automated tools.
We've had a chance to discuss many things today. If you could leave the audience with just like one key takeaway from our conversation, what would you have people know?
CDI is more than revenue. It is what ties everything together. If I were to think about three primary areas for healthcare that CDI links, it's rev cycle. We didn't document it. You can't code it easily. It's quality. So it's those readmission, length of stay, mortality measures, the risk-adjusted measures, where every document with every diagnosis can impact those PSIs and hacks. But then it's patient safety. So those details in the medical record that may go missed, that our CDI teams pick up on, that can truly help influence the care we're delivering to our patients. Those three buckets, CDI ties all of them together. And again, without getting it documented in the record, it doesn't mean it didn't happen, but it means it's been missed. So CDI is key to those three areas.
Thank you so much for joining me today. I've really enjoyed our conversation.
Thank you, Tim. And I appreciate the opportunity to come speak with you about CDI and the wonderful coding partnership we have here at AdventHealth.
Yeah, that's a partnership that I really value.
Thank you.
Thank you so much for tuning in to today's episode. Please make sure to like and subscribe to be notified when our next episode drops. We will see you next time.